A very good morning, everyone. So we'll be starting the refractive surgery instruction course in a couple of minutes. Sorry for the delay. Good morning again. I'm Dr. Sanjana. So today we will be talking about refractive surgeries. We will be mainly concentrating on PRK, LASEK, that is Microkeratome LASIK and Femto-lasik, and then lastly SMILE. So we know that the refractive surgeries are classified into lens-based procedures and cornea-based procedures. So today we will be focusing mainly on the cornea-based procedures. In that we have mainly the tissue subtraction and the tissue addition techniques. Now the tissue subtraction techniques, mainly we have the surface treatment, which includes the PRK and the EPI-LASIK. So the main mechanism is we use the excimer laser, the argon fluoride system. It has a wavelength of 193 nanometer and it ablates by the principle of ablative photo decomposition. So what are the indications of PRK? Now, usually we consider PRK in patients with low to moderate myopia less than 6 diopters, and some people also do consider more than 6, but always the chances of HAZE are a little more, so we need to preferably limit to 6 diopters. Then in case of hyperopia, preferably about 3 diopters, less than that. Then in cases of astigmatism, we limit up to 4 diopters. And then in cases of deep orbit, so when there is a sunken eye and when there is a narrow palpebral aperture or a deep set eye, so in those cases PRK would be preferable, because in cases of LASIK and SMILE, the suction might be a little difficult, so surface ablation would be much easier. And then in cases of borderline thin corneas where the residual bed thickness is less than 300, so usually they say the RBT should be kept about like say 250, but to be on a very safer side, if we keep about RBT of 300 micron, and in cases of where the corneal thickness is less, in such cases instead of going for LASIK, PRK would be preferable and safer. And in cases of flat corneas and steep corneas, so we know that in LASIK we have chances of free cap in a flat cornea and buttonhole in steep cornea. So in such cases again prefer PRK. And in cases of form fruste keratoconus, a little bit detail of it I will be telling later. And those who engage in contact sports or occupations like in military, where they have a risk of ocular injury. So in such cases, flap-based procedures would be a little risky because it can cause flap dislocation if there is trauma. So surface ablation would be better. And also lastly, in cases of retreatment following corneal procedures. So if we have to go for an enhancement where the patient has already undergone like LASIK or SMILE, then the retreatment option PRK would be better. So this is the basic refractive workup which we do for all cases. So first of all, look at the age of the patient. It should be more than 18 years with a stable refraction of at least not changing more than 0.5 diopters in 1 year. Second, always ask for the contact lens history, because first of all, contact lens, long-term contact lens users will have dryness, and that has to be ruled out. And also, if they are using contact lenses, we need to tell them to be off contact lens. In cases of soft lenses, usually a minimum of 1 week, and in cases of RGPs, at least about 3 weeks they should be off contact lenses before we go for refractive surgery. Then we usually do the normal checkup of intraocular pressure, then autorefraction, and uncorrected and best corrected visual acuity, and we also do the manifest and cycloplegic refraction, and a thorough detailed slit lamp evaluation has to be done. So here, rule out if there are presence of any scars, opacities, or if there is presence of any endothelial guttae, any other findings in this slit lamp examination should be noted. Then we do a dilated fundus examination. Then corneal topography, preferably pentacam as it's more accurate. And then we have the wave scan aberrometry. We also have to look at the pupil size both in the scotopic and mesopic conditions. And we do a dry eye evaluation. The simple dry evaluation would be enough in cases of Schirmer's 1, 2 and T-BUT. And if available and in special cases, we would do specular microscopy and ASOCT. So coming to the basic steps of PRK, we have the first one, which is the epithelial removal, following which we gave the excimer laser ablation, and then we use mitomycin C, and finally the application of bandage contact lens. Now the epithelial removal can be done in various ways, but practically what we follow would be mechanical, chemical and the laser techniques. Now in cases of chemical techniques, we usually use alcohol, that will be ethyl alcohol, and we use 20% ethyl alcohol. And normally what we do here is, this is what we see here is the alcohol well. We keep it on the cornea, and then we put a few drops of it inside the alcohol well, and we wait for about 20 to 30 seconds, and following which it is thoroughly washed. So always make sure that it's completely washed so that it does not cause any toxicity to the surrounding conjunctiva or the limbal cells. So once it's washed out completely, then we go for the epithelial removal, which can either be done using a Merocel sponge, or we can even use a hockey stick. Now this is a case of mechanical debridement, so where we see that we use a rod and we are removing the epithelium. So always make sure that do not go too much to the periphery, because it causes delayed epithelial healing. So it should be just about maximum of 8.5 to 9 millimeter. And also make sure that you do not make the bed very dry or very wet, because during the time of ablation it can cause later on undercorrections and overcorrections. So completely remove the epithelium. You can even use a Merocel sponge and make sure that the center part is clean. There should be no island of epithelium left between. So there is also another method of epithelial removal, which is called as TRANS-PRK. So here we use the laser itself. This is called as the Johnson one-step, no touch technique. So here what we do is basically, as you can see here, in transepithelial PRK, we do not use alcohol or we do not go for a mechanical debridement. Instead, the laser itself will ablate the epithelium first, followed by the stromal ablation. So we have to remember one thing here, that epithelium is slightly thinner in the center compared to the periphery. In the center it is about 55 microns, and in the periphery it goes up to 65 microns. So it does a differential ablation based upon the thickness of the epithelium, and following which it does the stromal ablation at the same time. Now in cases of different machines, there are different ways it's been shown. This is actually a picture of what we use, that is the Alcon EX500, where it has got an option called as Streamlight. This is what we have to go for in cases of transepithelial PRK. Now this is in case of Schwinn-Damaris, where we use the scanning slit technology. Here again it does both epithelial removal and the stromal ablation together, that is the transepithelial PRK. So one thing we need to understand, so after this, after the epithelial removal, we go for the excimer laser ablation, and once the ablation is done, we will go for application of mitomycin C. Now, mitomycin C, some people prefer, some people don't, but preferably it is good if we use it so that the chances of haze would be lesser. So we use 0.02% mitomycin C, and we keep it for about like 10 to 15 seconds, of maximum up to 20 seconds. And after that, give a very thorough wash and then put a bandage contact lens. So now coming to a little bit detail of the type of ablation and all that. So first we have what is called as a wavefront optimized and the wavefront guided ablations. Now to understand this simple concept, we need to first know what is a cosine effect. Now if we can see over here, the cornea is spheric, and let's say that the laser beam is falling here and also in this area. So if we see that the same laser beam which is falling here and also is falling in this particular area, here the surface area becomes a little more compared to the central part. So what happens is the amount of energy which will be delivered to the periphery will be lesser compared to what is being delivered in the center. So when there is more amount of ablation happening in the center compared to the periphery, it leads to a little irregular pattern of ablation and will give rise to what is called as spherical aberrations. So to prevent this from happening, we do what is called as an optimized ablation profile. So in this, it is adjusted in such a manner that the laser energy that is delivered to the periphery is a little more compared to that of the center in a controlled manner. So it gives an optimized ablation, and thereby we do not induce the spherical aberrations. So this is what is called as a wavefront optimized ablation pattern, which we normally use. Now there is also something called as a wavefront guided. Now what is the difference between the two is that in case of wavefront guided, what we do is already there will be some pre-existing higher order aberrations which we take into consideration, and we treat them also along with taking care of intraoperative induction of aberration control. So the main difference is in wavefront optimize, we don't take into consideration the previous aberrations. We just make sure that intraoperatively we do not induce anything. But in case of wavefront guided, whatever the aberrations previously the patient has will also be treated. So in case of a normal eye, what would you go for? Either a wavefront optimized or wavefront guided. See, wavefront optimized would be sufficient enough provided that the patient is not having very high preoperative aberrations. Now we also have something called as a topo guided abrasion, that is PRK. So which is basically what is a new thing which has come called Contura. Dr. Aparna will be talking about it later. So now just coming to the post-operative complications, a few of them which can be commonly encountered. The first important one is the pain. So usually the pain is predominant on the first evening of PRK treatment and gradually will improve over the next 24 hours. And usually we give them oral analgesics and topical NSAIDs, preferably the preservative-free ones, and they do pretty well. So we also have second one is the epithelial problems. So the epithelial problems are, it can be in the form of delayed epithelial healing. This can happen because of alcohol toxicity, or if the patient has a preoperative dryness, and in cases of diabetes. And they can also have persistent epithelial defect, which can happen again because of the preservatives in the medicine and because of medicine toxicity. Or there can be some recurrent corneal erosions. So in all these cases, always preferably use preservative-free lubricant drops and even lubricating gel. Next thing is dryness. So dryness, again, it can happen because of the ablation of the corneal nerves and also because of the pre-existing dryness. So in this, again, we normally use the preservative-free lubricant drops excessively. We can also add them on cyclosporin 0.1% BD, and if it is very severe, we go in for punctal plugs. But also make sure that if there's any meibomian gland, if there is any MGD, then always that has to be treated in the form of tablet doxycycline, or again along with the warm compress and lubricants. Next thing is a corneal infiltrates. So it can either be in the form of a sterile infiltrate or an infective one. So whenever there is an infiltrate, always think as an infective one unless proven otherwise. So if this is a case like this, now first ask for the symptoms if the patient is having too much pain, redness, watering, photophobia. So usually in cases of sterile infiltrates, there is not much of symptoms, and usually the signs are also less in terms of congestion is much lesser, and not much of an anterior chamber reaction, etc. So this is a case, but still we always go ahead with scraping, and we make sure that it is not an infective one. And then the sterile infiltrates will do good with the topical steroids with antibiotic cover, and of course the lubricants. So this will be a case of infectious keratitis. So here if we look at it, there is a lot of congestion, the circumciliary congestion, then there is anterior chamber reaction, and there is a dense infiltrate in the center. Also there is hypopion, and patient will also be very symptomatic. In these conditions, always do the scraping, look for the organism, and then start them on the fortified antibiotics. Next thing, we have something called undercorrection and overcorrection which can happen. So intraoperatively, if the bed is like too wet, and it can cause undercorrections, and also it can be because of the postoperative haze or even scarring, or if there is an aberrant or abnormal wound healing. So then there can also be overcorrection. So overcorrection can be because we have attempted a higher correction, or if the bed was very dry, that is excessive stromal dehydration prior to ablation can cause overcorrections, or if there is a low humidity in the room, and if excessive use of topical steroids or excessive mitomycin C when used can cause overcorrections. Next thing is a decentered ablation. So here we see that the center cross should usually be at the center of the pupil. Now in case, let's say, the patient is excessively moving, or even during, even before we start the surgery, it has been slightly off the center and the ablation is continued, then it can lead to a decentered ablation. So usually when we do a pentacam, this is how the decentered ablation would look, wherein we see that it's slightly decentered here. So this can usually give rise to some irregular astigmatism, and the visual acuity might be affected. So the next thing is again irregular astigmatism, which can happen because of decentered ablation, or sometimes if postoperatively they develop ectasia, and if there is any differential wound healing because of annular haze. Then this is a case of corneal haze. So if we look at this, the second picture here, so this was the person who presented to us. He had undergone transepithelial PRK for hyperopic treatment elsewhere, and he came to us after 3 months. He had irregular astigmatism, and he had developed an annular haze. So in that case, we just put him on low-dose steroids and also cyclosporin for 2 months and lubricants. Though the haze did not completely disappear, he did improve in terms of the astigmatism and the visual acuity. So the increased chances of haze happens when we go for a deeper ablation, like more than 80 millimeter. So that's why we usually keep it up to 6 diopters. So the deeper we go, the chances of haze will be more. And in cases of myopic corrections, as I said, more than 6 diopters, and hyperopic more than 3.5, the chances of haze are more. And in cases of smaller ablation zone, or when there is excessive use of, exposure to ultraviolet radiation. So that's why we always tell our PRK patients to use UV protective glasses after the surgery. And if they have any ocular surface disorders, then also in cases of retreatments, when they've already undergone probably a PRK before or a LASIK before, and we go for a retreatment, then the chances of haze are more. So in these cases, obviously we use mitomycin C to reduce the chances. So this is how our Wavelight EX500 chart looks like, which gives us the details about everything as to what is the refraction and what exactly is optical zone, etc. And here it also gives us how the pattern of ablation is. And intraoperatively, it also gives us the pictures and it tells us whether the treatment has been well centered or not. So just one of the picture of pentacam, where if you look at it, they may not be very clear over here. The thickness is 479. It's slightly borderline. So in this case, again, the patient had a power of about minus 3 diopters. So in these cases, I would prefer to go for something like PRK to be on a safer side. So this is a Berlin-Ambrosio display of the same patient. Now let us see, there's one more option lastly, what is called as a PRK extra, where we will be combining PRK with C3R. So what are the indications of this? Whenever there is a borderline topo or some topographic changes in the form of an asymmetric bow tie or a skewed radial axis and inferior steepening and a thin pachy, and in cases of significant posterior elevation, it's always better to combine it with a cross-linking to be on a safer side. So just an example, this is a picture of a pentacam. So where we can see that the thickness is about 490 micron, and also if you look at the bad display of this, there is both anterior and posterior elevation along with some deranged D values. So in these cases, it's always better. First look at the age of the patient, especially in cases of younger patient. If so, then always better you combine it with cross-linking, so that the chances of future post PRK ectasia could be controlled. Now lastly, just I'll be showing a small video on LASEK, that is So that was pretty much about PRK in short. Now this is a case of LASIK. Just a minute. So here again what we do is we keep the alcohol well, and then we put ethyl alcohol 20%, wait for about 20 to 30 seconds, wash it thoroughly. After that you can start scraping the epithelium, and in this we do not completely remove the epithelium, we just keep a hinge of it. So just look at it. So in case of PRK, we would completely remove the whole epithelium and then go with the ablation. But in case of LASIK, a small hinge of it is left behind so that it can be reposited back. Okay, sorry. So then we follow with the laser ablation and then wash thoroughly, then reposit back this epithelium which would act as a flap. Following which, just put a drop of antibiotic, put the bandage contact lens, and that's the end of the surgery. So next we would be talking about the microkeratome and femto-lasik. So I would like to invite Dr. Sanjana to take over.
Hello. Yeah. Good morning, everyone. Moving on with the presentation, the next we have is flap-based procedures. I'll be covering blade LASIK and femto-lasik. Step 1 is patient selection. I think the first step is to get talking to your patient. The things that you want to rule out while talking to your patient is type A personalities who just want to get the surgery and just go back home and have a lot of expectations. So this is what you have to rule out while you talk to the patient. Sports players, because there are high chances of flap dislocation due to trauma. Defense, army and police, again high chance of flap dislocation due to trauma. While you talk to your patient, it's important to set realistic expectations. You have to tell them that there will be some time taken for the quality of vision to improve. Patient will have post-op dry eye and should be ready to use lubricants for quite a while. Again, you have to counsel them regarding the refractive predictability, which will be within plus to minus 0.5 diopters. Please clearly explain your patient the need for presbyopic glasses above 40 years of age, and also explain the importance of patient cooperation during the procedure. That is very important because most of our LASIK complications is when the patient is not cooperative, doesn't know where to look, and keeps moving his eye. That increases the chance of complication. Step 2 is pre-op evaluation. There are few checkpoints that you have to pass through before you post your patient for a LASIK. First would be, of course, refraction. You have to check the old and present glass power. Basically, you check for stability of refraction. Cyclorefraction is an absolute necessity to rule out pseudomyopia. You have to rule out phoreas to prevent decentered ablation. Of course, a dilated retina examination to rule out periphery retinal degenerations that need barrage laser. Example, lattice with holes, etc. This is because the IOP raises up to 120 to 130 mm of mercury during blade LASIK and 20 to 30 during femto-lasik. Schirmer's 1 and 2 and T-but. Very severe dry eyes is a contraindication for LASIK surgery. Moving on to the most important, that is your topography. We should do a pentacam, and the pentacam should be done with 1 week of soft contact lenses and 3 weeks of RGPs for all patients. The various checkpoints that you have to pass through in the pentacam is the K1, K2, K-mean, sagittal map, thinnest Pachy, angle kappa, and the pupil size. I'll be taking each one. The K1 should be more than 40 diopters. Each 1 diopter of myopic ablation reduces your flat K by 0.8 diopters. The final K1 value after the treatment should not go below 34 diopters. So this is something that you have to calculate while you see the pre-op pentacam of the patient. Next is your K2 value. It should be less than 47.2 diopters. Each 1 diopter of hyperopic ablation increases your K value by 1.2, and the final K2 should not go beyond 49 diopters. When it comes to the K mean, a K mean between 41 to 46 diopters is good. For a K mean below 41, there are chances of a free flap, and for above 46, there are chances of a buttonhole. In the sagittal map, you have to rule out FFK. The Kmax should be less than 47.2. The inter-eye difference in the Kmax should be less than 1.9. And the inferior-superior difference in the 5 mm zone should be less than 1.4. The thinnest PACI is important because you will use this PACI for calculation of your RSP. For each diopter, assume the pachymetry to reduce by 15 microns, and the final RSP should be more than 300 microns. Angle kappa is to check the x-coordinate of the pupil center, which should be less than 0.5. This is to avoid like halos if your ablation is not centered well. Let's have a look at this pentacam, and let's assume that this patient wants a LASIK procedure. These are the values that we'll be looking at. The K1 I said should be more than 41. This is 42 here. K2 should be less than 47.2. It's 45.5. K mean is between 41 to 46. Astigmatism is 3.5. And the X value you're seeing over there is minus 0.32, which is less than 0.5. Thinnest local is 529 and Kmax is 45.7. Moving on with the residual stromal bed calculation, the ablation depth is calculated as 1/3 into dioptric power into the optic zone in millimeters to the whole square. The optic zone is calculated using the scotopic pupil size. Your scotopic pupil size is something that will show when the pentacam is taken in a dark room. You add 0.5 mm to that, which will give you your optic zone. For example, a patient with 2 diopters and an optic zone of 6 mm, thinnest PACI of 400 microns, the calculation of the RSP is given as such: 1/3 into 2 into 6 to the whole square is 36 microns. So the RSP is 500 minus 36 minus flap, which will give us 374 microns. I'm sorry, the thinnest PACI there should be mentioned as 500 microns, not 400. Or for rough calculation, 1 diopter will need ablation of 12 microns for a 6 mm zone and 14 microns for a 6.5 mm zone. Keep a minimum RSP of 280 to 300 microns. Pre-operative counseling, this is very, very important. You have to counsel the patient regarding 5 senses. First thing, touch. You have to tell the patient you will feel no pain during the procedure. However, there will only be this sensation of pressure as anesthetic drops will be applied. Sight. Patient has to look at the target green light. It might not be visible all the time during the surgery, like when you're applying pressure. But he doesn't have to go looking for the green light. He just has to remember to keep looking in the direction where it was last seen. Sound. Patient has to be counseled that if it's a blade LASIK, he will hear a small mechanical sound while the blade creates a flap. He doesn't need to move or get scared. Smell. With the old excimer lasers, not the new ones, with the old excimer lasers, there was this certain burnt smell after a high amount of ablation, and sometimes patients would say that okay, something is burning in the OT. You have to counsel them, those are just excimer vapors, but this is not much with the newer machines. And the last, calm mind. Patient can be given pre-op alprazolam 0.5 mg if they're very nervous on the day of surgery. When you're going in for your surgery, what you have to plan is the optic zone. Like I told you, it's 0.5 mm larger than the scotopic pupil size. It's important to plan the flap diameter accordingly. You will need a larger flap in hyperopic and mixed astigmatism ablation. That's because these surgeries need ablation in the mid-periphery. Smaller flaps should be chosen in case of high refractive errors to save tissue. But then again, the flap should not be so small that it should come within the scotopic pupil size. There's a fine balance between tissue saving and a narrow optic zone. Again, flat corneas, we have to keep a smaller flap because there are chances of free flap and we don't want it to go all the way down. This is a nomogram. You can look at the steepest K values. As the steepest K values are low, the flap diameters are smaller. As the steepest K values keep going higher, the flap diameter can be taken as bigger. These nomograms come with every microkeratome, and this one was put up in our OT. For an example, I just added it here. So this is pre-op. Before you start the LASIK surgery, it's important to mark the cornea. This is to assist in the correct orientation in case of refrap. This is a patient. Let's assume this is the head side of the patient. You have the right eye and the left eye. Patient is lying down. On the right side, you make a mark in the inferonasal quadrant. On the left side, you make it in the inferotemporal quadrant. It's important to tape the other eye shut to prevent decentered ablations due to manifest tropias or phorias. This is the example of how we plan a flap creation. I'm sorry, I don't have a pointer here. If you can see the refraction on the top, the refraction value is given over there. The pupil size is given. The K1 and K2 values are given. The K1 and K2 values are given. Also, we have the optic zone, transition zone, and the ablation zone. Here, over here, we have the epithelial thickness, the flap thickness, the cornea thickness, and the residual stroma. Moving on, this is how a LASIK surgery, a blade LASIK surgery is done. So the first step is, you put the microkeratome, create suction, and lift the eye slightly. This is how a flap is created. You give the forward pass and the reverse pass. Before giving the forward pass, it is important to ensure, before giving the forward pass, it's important to ensure that nothing comes on the, while the blade passes, you'd want to make sure there's no obstruction. We'll just move faster. After we've lifted the microkeratome, we can see the flap is right there. You just gently lift the flap and make like a taco fold over there. So if you have a look at the bed shouldn't be overhydrated or dry to prevent over or under correction. Once we've checked the centration, we can move forward with the laser ablation. After laser ablation, we give a wash. We give a liberal wash to make sure there are no interface debris. You can also wash the underside of the flap over there. Once that is done, we move forward and reposit the flap gently. As you can see, during the procedure, patients often move their eyes. So you have to keep talking to the patient. This is what you get after the surgery. Like, you can check for the centration of the patient during the surgery over here. Anything on either sides, one above or one below, is an okay centration. Post-procedure, what's most important to check, that is on table itself, is the guttering. Let's assume this dotted line is the flap, and that is the bed, and this is the eye of the patient. You have to make sure that the flap has it's centered right well. You know, the guttering on either sides, it shouldn't be too much on this side or too much on that side. In that case, you just take a Wexel and nicely iron it out and make sure that the flap is sitting well on the bed. You have to instruct the patient to not touch the eye, rub the eye, post-op medications, of course, steroid and antibiotic combinations, regular review, no face wash for a week, no hair wash for 10 days, no eye makeup for 2 weeks. This is very important. No swimming in lakes or beaches, even for normal patients. It's not something specific to LASIK, but in clean pools after 2 months. Moving on, we go ahead with Femto-lasik. Femto-lasik is a procedure which uses femtosecond laser platform for flap creation and excimer laser for stromal ablation. The additional steps for Femto-lasik is pre-op, inform the patient that he will be shifted or she will be shifted from one machine to another. So you have the femtosecond machine for flap creation and the excimer machine for laser ablation. And you also have to plan the cone size, because in femtosecond flap creation you will be docking the patient. The cone size is chosen with the white to white, which is again available on the Pentacam. You need a small cone size for a white to white of 11.7 to 12.1, medium for 12.2 to 12.7, and large for a white to white more than 12.8 mm. Again, the planning for femto flap creation as given over here. You have the flap data. Of course, you have the refraction above, the diameter of the flap, the thickness of the flap, the side cut angles, and the hinge. All of this is something that you have to fit into the machine before femto flap creation. This is a video of how the eye is docked. That is the cone. And this is a video of once after docking, how the flap creation takes place. So here you can see femtosecond has created a flap. After the flap is created via femtosecond, you have to go ahead and dissect the flap. Sorry. So this is how it looks. You have these multiple femto bubbles. You have to go ahead and first use this kind of a dissector to kind of, delineate the flap all around. Go in gently, and yeah. So that's how you dissect the flap all around. You start with dissection at the hinge area and then come downwards. Movements should be very, very gentle, because the femto flap is very thin, it's very delicate. After this, you shift the patient to the excimer machine for ablation, and the other steps continue same like how our blade LASIK is. You give the excimer laser, reposit the flap, put a drop of antibiotic, and post-op medications are the same. The complications that can occur with flap procedures is first flap-related complications, free flap and buttonholes. Let's assume here that this is the flap, this is the bed. Free flaps is when there is nothing that is anchoring the flap to the flap bed, and you get a flap that is like this. In that case, the pre-op marking of the flap and the eye itself helps in correct orientation after excimer laser ablation. So you just lift the free flap, give excimer laser, and then reposit the free flap using this pre-op orientation marker. In the case of buttonholes, which takes place in steep corneas, let's assume this is the buttonhole area. Please don't go ahead with the LASIK. Just put the flap back, and about 3 to 6 months later, do a PRK for the patient. Microstriae and macrostriae. Microstriae are shown in this picture here. They are just Berman layer folds, and they are visually insignificant. They usually need no intervention. Whereas macrostriae are full thickness flap folds. They have to be ironed out. I'm sorry, since we're running out of time, I can't complete that. They have to be ironed out using Vexil sponges perpendicular to the fold. Let's assume if your macrostriae are in this direction, the ironing out has to be in this and this direction using 2 Vexil sponges. Epithelial ingrowth, when the flap opposition is not great to the bed, then epithelium can grow from the surrounding area under the flap. And usually epithelial ingrowths that are not in the within the pupil and they're really little need no intervention. If suppose they're really involving the pupil and there's a large amount involved, you have to lift the flap, give a nice wash, debride over there, as in remove the epithelial ingrowth, and then reposit the flap back. This is a case of diffuse lamellar keratitis. So diffuse lamellar keratitis is due to some secretions, meibomian secretions, or some interface debris that go within the below the flap and cause like this an immune reaction. This was a case that had DLK post LASIK, and patient responded well to topical and oral steroids and cyclosporin. This post-LASIK scar, this LASIK was done elsewhere. The cause of this is just sometimes when the intra-op manipulation is too much, patient can have a scar like this. To conclude the advantages of Femto-lasik and blade LASIK, blade LASIK is cost effective, needs one machine and less chance of suction loss. Femto-lasik is more precise, thinner flaps, less free caps and buttonholes, less rise in IOP, but it does have higher chance of DLK because of the femto bubbles and the flap dissection, and it does have better flap adhesion. This is my last slide. If you just have a look at the ASOCT of the flap that is created with LASIK, the blade LASIK and Femto-lasik, the Femto-lasik creates a flap of uniform thickness all around, whereas the blade LASIK, because of the shape of the cornea, creates a flap that is thicker in the periphery and thinner in the center. Thank you so much.
So the next one is about Relax Smile. So may I know in the audience how many of you are performing Smile or planning to perform in the near future? Okay, that's very good. Yeah, so we know that we do it with using the femtosecond laser system with Visumax, and it delivers femtosecond pulses with a wavelength of 1043 nanometer and a frequency of 500 kilohertz to create an intrastromal refractive lenticule. So the preoperative evaluation is pretty much the same as I've already mentioned before. Now this is how we do the entry in the Visumax. So in the Visumax we have the left and the right side monitor. In the left side monitor we will be entering all the details as to what would be the refraction, optic zone, etc. So now if you look at it here, so first it asks for the manifest refraction in terms of sphere, and then we add the cylinder here and the axis. Then down when we come to the lenticule parameters, we have the optic zone. So the normal optic zone we keep about 6.5 millimeter, but in cases of slightly borderline thin corneas, when we want to save some tissue, then we would keep about 6 millimeter. We can even increase it maximum up to 7 mm, but ideal would be about 6.5. And the next is the transition zone. The transition zone in cases of sphere we usually keep it 0, but if there is a cylinder it will be 0.1. The next one is called the minimum thickness, and the minimum thickness usually we keep about 15 micron, but again if there is a borderline thin cornea, if we want to save some tissue, we can even keep up to 10 micron minimum, and maximum we can go up to, let's say, 25 to 30 microns. And finally it gives a side cut angle that is 90 degree. And then it goes to the next one, that is the cap parameters. So for the cap parameters, first on the top we need to enter the K value, which will give in terms of corneal radius, and then we have to enter the pachymetry, which is the thinnest pachy which we see on the pentacam, and then we have to select the cone size. So as already been mentioned before, we know that the cone size depends upon white to white, and usually we go for a small cone unless the corneal diameter is large. And the next is the cap parameters. So in the cap parameters we have mainly the cap diameter and the thickness. So the cap diameter will always be 1 millimeter more than the optic zone. So in this case I showed you that the optical zone was 6.5, and thereby the cap diameter will be 7.5, and the thickness we usually keep 120 micron as a thickness. Some people also have tried even with 100 micron and 160, but ideal would be 120. And down it gives us the incision parameters, that is the incision what we make at which position and what is the width. So the width of it is usually as a beginner they say about 4 millimeter would be better, and it can be kept least up to 2 millimeter. So in my case I have used 2.5. The next thing after the entry is done, then we go to the right side monitor to just check as to everything is come properly. So here again it tells everything, it sums up pretty much everything as to what is the cap diameter, what is the thickness and the lenticule diameter, what is the residual stromal bed thickness, everything. And also one more important thing here, if we look at this is we have something called as the standard mode, fast mode and the expert mode. So these are the different modes that are available, and usually there is a slight difference in terms of the time taken for the laser delivery, and also regarding the spot size and regarding the energy levels, etc. So for each one of them, but ideally what we use would be the expert mode. So you press on the expert mode, then it goes to the next screen. Now in this screen, it again shows us about what is the spot distance, what is the track distance, and the energy offset, etc. So if we have to tell in brief what is the spot distance and the track distance. So basically, if you look at this, what happens is there are two dots in this is, let's say this is one part of the laser energy, this is where the next laser happens. So whatever the distance between the two will form the spot distance, and then the track distance would be if this is one track and this is another track. Now the distance between these two would be the track distance. So these manipulations and slight changes would be done basically because it helps in, it actually is a surgeon preference as to how they want the laser pattern to be, and also whether it aids in the lenticular dissection easier or not. But normally what parameters we keep are like this. We go to the expert mode and we keep a spot distance of 4.5 for the lenticule, and for the lenticule side we keep 2, and again for the cap it's again 4.5, and then the cap side cut is 2. So it's a little bit too much details of it, but just roughly to say these are the parameters what we use. And then we have the energy offset. Now the energy offset is basically how much is the energy intraoperatively. So it usually ranges, if we keep low energy, let's say about 28, then again it will be the dissection would be a little difficult, and if we keep a very high energy, then it can cause an opaque bubble layer. So normally we keep about, like, say 32 to 33. So now coming to the surgical procedures of SMILE, first we have the docking. Now this is how it's done. So basically the treatment cone, this is the treatment cone which is available in the form of small, medium and large, and we know that when the white to white is about 11.8 to 12.1, which is the case in most of the patients, we go for the small cone. Now always make sure that the undersurface of the cone is clean, and we do not touch the undersurface of the cone, because if there is any sort of any fingerprint or any debris which is seen on the undersurface, then again the laser delivery does not happen through that. So make sure you would never touch the undersurface. Now this is how the docking is done. Always tell the patient not to squeeze, not to move, just look straight at the fixation light, and gently the suction cone would come and touch the cornea. And once it's about 70 to 80% this thing, we actually go for the suction. So once 70 to 80% docking is done, we say suction on, and when we press the button where the suction gets activated. And once the suction is activated, we, even before we go ahead with the laser delivery, what we should see is a centration. So here in case of SMILE, we do what is called as the visual axis centration. We tell the patient to look at the green blinking light which is seen in the center, and then we center it across that, and it's pretty much coinciding with the pupillary center unless the angle kappa is too high. So after the centration is checked and it's normal, it's fine, then we go ahead with the suction. So when we press the button for suction on, now this is how it is seen. So basically it has got 5 bars. Now if it is at least it should be minimum 4 lights out of 5 to say that it's a adequate suction. But if we just see 1 or 2 lights, that means it's a very low suction. Please do not proceed with that, because intraoperatively it can cause suction loss. So make sure it's either 4 or 5. Now after that we go ahead with laser delivery. Now before laser delivery, one thing I would say is the docking mistake, what should not be done. If you look at this patient, there is some amount of fluid which is coming over here. So here there is so much of fluid which came, and again more amount of fluid came. So always make sure there is no excessive amount of fluid, because remove all the excess fluid, otherwise this excessive fluid may come in between and then suddenly it causes a suction loss. So always make sure you remove everything and then go ahead and then do the suction and the laser delivery. Now these are the stages of laser delivery. Now first we have centered it on the visual axis. Now once the suction is on and it's an adequate suction, we make sure we proceed. This is the posterior plane formation of the lenticule, the side cut, then the anterior and incision. So after the 4 planes have been formed, then we move ahead with the dissection. So during dissection, first you delineate the or open up the incision. After you open up the incision, we go ahead delineating the anterior plane on the left side preferably, and then we go ahead with delineating the posterior plane on the right side. Then we go ahead with the dissector and dissect it smoothly from one side to another, the anterior. Now I come to the posterior. So dissect it thoroughly all over, And always leave a small tissue bridge over here somewhere so that the lenticule doesn't get folded up. Then remove it out with a lenticule forceps, put it on the surface of the cornea and some saline, and make sure that the lenticule is full and complete. So after this, usually we do not do the interface wash, but some people do interface wash also. But if there is excessive amount of manipulation, then you can go ahead with interface wash, otherwise not necessary. Now this is what is called as the ideal bubble pattern. Now intraoperatively, we do have a sign called as a gas bubble escape sign, which says that it is an ideal bubble pattern. Now just look at this. Now I open up an incision and we can see there's some gas bubbles which are escaping over here. Now I go ahead with delineating anterior plane. Suddenly the clarity improves. So if it's not very clear, now look at this. Now this is before the escape of gas bubbles, and this is immediately after the escape. So before to after, there is quite significant difference in the clarity. So once the gas bubble escapes, there is a sudden improvement in the clarity of the interface, which means that it is a very good bubble pattern and the lenticular dissection becomes very easy. Now coming to some intraoperative complications that can happen. Now how it can be avoided and how it can be managed to get good visual outcomes is what I would say here. Now the first one is the suction loss. Now when does the suction loss happens? So you know that when the patient has got a very deep set eye or a narrow palpebral fissure, or when the patient is excessively squeezing and the suction is not tight enough, in such cases suddenly there can be a suction loss. Then even in cases of very flat corneas, or if there is a loose epithelium, or in cases of excessive reflex tearing, and if the patient suddenly moves and he is not able to maintain his fixation, in these cases the suction loss happens. Now this is a case where you said suddenly the patient moved and then the suction loss happened. Now what do we do in this case? Now it depends upon what stage the suction loss has happened. Now let's say that if the suction loss happens, now just a minute. Yeah, so so suppose if it happens less than 10% of the lenticule cut, so then in that case we can redock and we can proceed again with smile. But during the lenticule formation, let's say more than 10% has happened and now the suction loss happens, in such case we cannot do smile, we will have to convert it into a surface ablation or LASIK. Then the third is if it happens during the lenticule side cut. So during the side cut again we can redock and we can continue with this. Just decrease the diameter by 0.2 to 0.4 mm. Then finally during the cap cut again, if it happens, we can redock and repeat it from the cap cut, and we usually reduce it the diameter by about 0.2 to 0.4 millimeter. So the next thing is the vertical gas breakthrough which can happen. Now for example, let's say this case, now the patient has got multiple scars over here. So in this case, do we proceed with smile? Ideally no, because we do see that there are some anterior stromal scars. So what happens is during the time of femtosecond laser delivery, there will be escape of these gas bubbles through these scars onto the surface, and the further laser delivery in that area does not happen. Now in that area, if you're trying to dissect, then it will be too hard and it can give rise to a buttonhole. So if the scar is somewhere in the periphery, then it's okay, you can proceed with smile. But if it is somewhere in the mid periphery or the center, do not do femtosecond laser, smile. Preferably you can go in for a LASIK or even a surface ablation. And the third complication that can happen is called the opaque bubble layer. Now as you can see here, there are opaque bubble layers which is seen in this area. Now this can happen when the suction what we do is too tight and there is no space for the gas bubbles to escape, and they all get accumulated over there. So in such cases what happens is that dissection becomes a little difficult, though long term it may not have much of an effect, but the immediate post-operatively the visual acuity would be slightly affected and may take a little longer for the improvement in the clarity. Now the next one is what is called dark spots, as we see over here. Now this is a video wherein we can see the multiple dark spots, and after this, when we moved for the dissection, it was extremely difficult to dissect in the area of the dark spot. So in fact now I'm trying to open up the incision. Now even opening up the incision was so difficult because of the dark spot, because laser delivery has not happened in that area. So this usually happens if there is excessive amount of dryness, you have put a lot of paracaine and the cornea is very dry, and also if there is some debris which is blocking the delivery of the laser. In such cases there can be dark spots. So the next one is a posterior plane dissection. So normally we know that we do first anterior dissection, then the posterior, but sometimes if we go posteriorly instead of going anterior first, then the lenticule can get slightly stuck to the cap and it may be a little difficult to dissect it. Now just see here, I have delineated first anterior, I have also delineated the posterior well, but before entering, instead of going anteriorly, I inadvertently enter the posterior plane. So I have not realized till now that I have entered the posterior. I continue my dissection, and if you look at this area, it may not be very clear, but I can see that the lenticule is above my dissector. So that means to say that I have gone posteriorly, but yet at this stage I have continued the entire dissection posteriorly. And since already the anterior plane was delineated before, I go again and I delineate the anterior plane, and then again I go with the dissector and I start the dissection of the anterior plane. So once I complete the anterior plane dissection, now I see that the lenticule is sort of folded up over here, and then I go with the lenticule forceps, hold it gently and then peel it off from all sides, make sure it's free from all sides, and then I take it out. Then always put it on the cornea and check for the continuity to make sure that it's completely out. So the next one is a case of an entrapped eyelash. So if you can see here, this area, the laser delivery has not happened. So this is more clear over here in this particular area. So this patient basically had very long eyelashes, and suddenly one of the eyelash had just entered, and it was in between the cone and the cornea. So in that area the laser delivery did not happen, and then the dissection would be slightly difficult there. So always make sure that the eyelashes are draped very well and it does not come in the way of your laser delivery. So the next one is a case of epithelial defect as is seen here. So this patient, slightly the paracaine was put excessively, and the epithelium was loose and it caused intraoperative epithelial defect. So you see here that the epithelium was very loose in the area near the incision. Now I'm trying to go to the anterior plane, but it was kind of even difficult to enter the anterior plane, and I could just feel that the epithelium was just peeling off in that area. So the thing is, if it is a small defect, it's fine, it usually heals well. If it's a large one, just put a bandage contact lens and can be removed the next day or after 2 days. So here again, you should make sure that the cornea is not too dry. You have not put excessive amount of paracaine, which would loosen up the epithelium and cause this. Now this was a case of cap tear. So as you can see here that there is a cap tear in this area. So this can usually happen when there is excessive amount of manipulation, or if it's not very gentle, and then maybe in the beginner who is kept a very small incision, then if it's a rough manipulation, it can lead to a cap tear. And again, if it's a small one, it heals well. Put a BCL, does not really cause much of a visual effect, but in case if it's a larger one, then it can affect the visual acuity post-operatively. Now this is a case of a lenticule tear. As you can see here that the lenticule is torn and one part of it is still attached, and this part of it is torn. So this was a case of lenticule tear where what happened was, in this particular area the lenticule was stuck and it was just not coming out, and it was quite difficult to dissect in this area. So again I'm trying to dissect in that area. Now I think that the lenticule has come free, but then no, again I try to pull it with the forceps and I see that it's slightly torn and it is still stuck in that area. So when the manipulation becomes a little more, also there would be some cap edema and the clarity would be very much affected. So in such case we can't even really make out where exactly it is attached, and it would be slightly difficult, though I knew that this was the area where it was stuck. So I go ahead again and then I sort of free it out, and again I pull, then again I see that it's sort of attached. Generally this does not happen, but this was one of the cases that has happened to me. And whether it was anterior, posterior, where exactly it was attached, the clarity was very bad, but finally I dissected it out and removed it in toto. And even if it's torn, always put it on the cornea and just make sure that it's completely out and nothing is retained inside. So now coming to the post-operative complications. So first is the interface haze. Now interface haze can happen when there is suboptimal energy levels. So let's say if there is an OBL and there is a very difficult dissection and the patient has got a very sticky lenticule. Also in cases of, we have seen in cases of thicker corneas, there will be a difficult dissection because the lenticule is very sticky. So in these cases, immediate post-operatively you might have some interface haze. Next one is a case of interface debris, where you can see that there is debris over here. Now, when there is excessive manipulation, you enter inside the interface and you come out a multiple number of times, or if you have introduced some debris or some meibomian secretions, etc., inside, can cause this. And usually, if it is in the periphery, a very small amount of it, it's okay, it does not cause much problems. But if it is in the center, then usually it causes a lot of glare and visual problems. And also, if you have any doubt, if you think that there is some amount of debris, always intraoperatively give an interface wash to make sure that it's clear. Then this is a case of diffuse lamellar keratitis. Though it's not very common with SMILE, we do see this. So this can again be because of the introduction of maybe some meibomian secretions in the interface, so which can incite an inflammatory reaction. On the day one, this is how it was seen, and usually they respond very well to topical steroids. If they're not, then put them on oral steroids too, and they do pretty well, and can also add them on cyclosporin and lubricants. So the normal post-operative treatment, what we follow is we give antibiotics, preferably fluoroquinolones, usually maximum for up to a week, and we do give steroids, prednisolone in the tapering dose, and we give cyclosporin eye drops to prevent any post-op haze, and finally lubricants, preferably the preservative-free lubricant drops and gel. And so this I would like to conclude by saying that, so to do a very good relax SMILE surgery, everything right from the patient enters into the operation theater until they leave and intraoperatively, it's extremely important. Always tell the patient what they would be expecting, not to move their eye, not to move their head suddenly. Their cooperation is very important, and make sure that the laser energy are very optimal, and dissection should be very gentle, and do not keep the cornea very dry. So every step is extremely important to have good visual and refractive outcomes post surgery, so that we go and so that the patient is happy and the doctor is happy, and we go home with a big smile after doing relax SMILE. So I thank you all for your listening, patient listening. So now Dr. Aparna will be talking about contoura.
Good morning. So I'll be talking on contoura vision. So no financial interest. I have taken some slides from the ALCON, the USFDA study, and some videos from the Providence Eye Laser. So this contoura is both LASIK and PRK is done, and they were originally used in complicated eyes and for enhancement procedures. So recently they have been tried in the primary eyes. So this is more like a fingerprint to the eye. It's very unique to all like patients. So this was the first time that was used in the ESCRS conference in Barcelona, and this is FDA approved. This redefines the visual outcomes to a newer level. So the indications are -9 diopter spherical equivalent myopia or myopia with astigmatism, -8 diopters of spherical component, and -3 diopter cylinder at the spectacle plane, and age more than 18 years, and the refraction should be stable for over 1 year with less than 0.5 change. And contraindications are like very similar to the other procedures: the severe dry eye, other degenerative conditions, pregnancy, and immunocompromised states. So in this study they have achieved a different level of visual acuity, and there were 92.6% of them have achieved 20/20 vision, and 64.8% have achieved 20/16 vision, and 34.4% have achieved 20/12.5 vision. So this has achieved an extremely high rate of patient satisfaction with 98.4%, and this has outperformed even glasses and even contact lenses by 30%. And all the symptoms that they had while they used the glasses and contact lens have been reduced. The glare has been reduced by 4.8%, halos by 3.2%, starburst by 2.8% reduction, light sensitivity by 5.2%, and night driving symptoms by 8%. So the what is new here is we have 22,000 unique elevation points that is imaged and analyzed in this software algorithm. So coming to the treatment plan, we do a manifest refraction as well as the topo guided refraction using the Allegro topo laser system. So this is something new. And we take 8 scans, then we take the 4 best scans, and then we take the best one. And what the FDA study protocol says is there should be difference of less than 0.5 diopters in magnitude between the manifest and the cornea cylinder refraction, and less than 15-degree axis difference. And change the modified refraction to plano, which gives the study of the ablation profile. And if the ablation depth is less than 10 microns, you can proceed with contura. If not, you cannot. And there's something called as layer yoked reduction of astigmatism. This is a recognition of the fact that the aberration removal layer is linked to the refraction correction layer. Contura software calculates the results of this linkage. So we enter the manifest and the cycloplegic refraction. We zero down the astigmatism and sphere to see the ablation pattern for the aberration correction layer, and then enter the contura measured astigmatism and axis for the final correction. And the sphere that is now entered after adjustment for the spherical equivalent for the change in astigmatism. So this is the Allegro topolyzer system. It's a Placido disc corneal topographer. It has a good iris registration. It detects Meyer edges and also detects the pupil margins and also location of the corneal apex. So as I told, when we zero down the sphere and the cylinder, we see the aberration profile, and then this is the final profile. So it is individualized to all patients, and then all this data is been transferred to the system and to the laser machine. And then, as I told, there's a good pupil tracking system, and the laser is delivered just like the other procedures. So this is just an animation showing the same. So this makes the cornea more aberration free and more uniform. So this accurately corrects the astigmatism power and axis. As I told, it creates a more uniform and aberration free cornea. It also corrects the higher order aberrations along with the sphere and astigmatism. So these cornea, they are so featureless that it appears as if the topography was taken by an artificial lens. So this is the result of another study where they have even achieved a vision up to 2010, that is 6/3. So 6.4% have achieved that. And the LIRA protocol, as I've told, could be the new normal than 2020, that's the 6/6. So this brings about the full potential of the visual acuity at macula. So quantity is not that important, the quality is important. So the difference between the wavefront and the topo guided is the topo guided takes into the account anterior surface of the cornea, and the sample density is high. It is not dynamic. It is not dependent on pupil and accommodation. Whereas in wavefront, the entire optical system is taken into consideration. Thank you.
देख आ गया हाँ
So we now have the keynote address by Dr. Hossam Ziada, Assistant Professor in Ophthalmology from Azhar University, Egypt. Thank you for coming, sir.
Thank you. Thank you for having me in this prestigious meeting. I will talk today about the relaxed smile and saying to keep a smile, don't smile. And first of all, I want from all my colleagues doing a smile to keep smiling in my face. Yeah? The question all the time, PRK, LASIK, Femto-lasik, or smile. This is a question which is always asked about the cases, especially the suspected one, to do the PRK or to go to smile. But after a lot of studies, nowadays we have concluded that all the femto or the flap containing or the cut containing procedures are the same in lowering the cornea biomechanics, and their impacts are almost the same after the different studies in different parts of the world. So about the corneal resistant factor, this study for 6 months follow-up after surgery, they found finally that the preoperative corneal biomechanics changed to almost to the same extent on the 3rd month, the 6th month, and finally the 12th month after surgery. They almost equal in the smile and PRK. And concluded that both smile and LASIK procedures do substantially alter the corneal biomechanical properties, and the degree of tensile strength of the cornea is reduced to a statistically significant extent. So the question, if you have a case of thin cornea or high error, what to do? The same for the corneal hysteresis. The corneal hysteresis is an indicator for the corneal power and the impact of the ablative procedures on this power after surgery. So this study too, concluding the same issue, that in contrast to the stability of the corneal hysteresis and the corneal resistant factor measurements after LASIK, PRK, with mitomycin and without mitomycin, also with the LASIK, they showed that the impact will be greater if you add mitomycin C to the PRK than the mitomycin without PRK first, and finally with the procedure of a smile, the extent of changes is equal in both LASIK and the smile, but to much less extent with the PRK ablation, especially without mitomycin. But actually adding the mitomycin will decrease the power of the cornea for a time, not a permanent change. It may take about 6 weeks to recover from the mitomycin effect. As the mitomycin decreases the fibroblastic activity, which is the main core of the corneal power due to the collagen and the cross-linking process in the collagen of the cornea. So the mitomycin decreases the fibroblastic activity for a time after surgery, so decreasing the power, but it will recover within 6 weeks after surgery. So we have to stop and think again about that. Don't go for any cut containing procedure if you have any suspicious case. Because all studies about the corneal biomechanical changes after all these procedures alarming us about that. And please remember this term, which will help us about thinking, about deciding our ablative procedures in the different situations. The residual stromal bed is no more considerable alone, but nowadays this term, the PTA, which is the percentage of the tissue altered, or the percentage of tissue ablated is more considered as a safety margin, as a safety indices for your ablation depth. This term was put by Marconi Santiago in 2014, indicating this equation: the PTA equals the femto thickness, the flap thickness plus ablation depth divided by the central corneal thickness. The PTA more than 35% is a very high risk of developing the post-LASIK ectasia, and with 100% sensitivity, it's not apparent there, with 100% sensitivity of more than 40%. So you have to calculate your ablation depth and the flap thickness before going for correction of especially the high errors. If you have a patient with a normal corneal thickness, normal corneal topography and tomography, but the error needs a very large ablation depth, you have to think about that and calculate it first before going to your surgery, and don't pay attention to the residual stromal bed. You may leave an adequate stromal bed which is 300 microns or more, but still decreasing the power of the cornea. For example, if you have a patient with -6 diopter myopia, and the ablation depth will be around 80 microns, and the central corneal thickness in this patient is 510. If you are going for LASIK with the Moria, even the X90 blade, you will get a flap thickness of 110. So 110, ablation depth of 6 times 13 or 14, according to the machine you are using, you will find that the calculation of the flap thickness plus the ablation depth will be around 100. If divided by the central corneal thickness, which is maybe 500, you may find that the PTA will be more than 35, will be 38, I think. So if you find that the PTA exceeding the 35, you have to be careful. You have to think again. If more than 40%, you have to cancel, or undercorrect, or go for another procedures like the phakic ILs. So I have a lot of patients which I turn from the LASIK surgery to the Femto-lasik, doing femto-flap of 90 microns to save more 10 microns to correct me 1 diopter more, or decreasing the ablation depth and increasing the PTA percentage. So if you have a normal cornea but a high error, still you are in risk. Turning back to the smile, in my opinion, it's somewhat a complicated surgery because you have a lot of cut planes. The cap side, the lenticle side. I will skip all these slides because it's well shown by my colleagues about the steps and the operative steps of the smile. As we have a lenticle cut, lenticle side cut, cap cut, cap side cuts, a lot of cuts. What will you do if you have an intraoperative complication as suction loss at the early stage, at the middle stage, or the late stage? And yeah, we have a management plans, but still sticking with our cases. So let's go directly to the post-operative care. After showing the intraoperative complication showed by my colleague, about the post-operative care of the Rayleigh smile, which is shown to our patients as a magic procedure. you will find a very delayed visual recovery. Some of our patients may have 2 weeks or more. Yeah, just 1 minute. Thank you. Will have 2 weeks, 3 weeks, or even 1 month to get a visual recovery and be satisfied. And finally, they are not satisfied because they skipped the PRK because of the delayed recovery. What to do if you have a residual error? Up till now, there is no solution for the residual error after the SMILE, but you have solutions after LASIK or Femto-lasik to correct your residual errors. Then what to do if you need a customized ablation like Contura or like the patients with high cylinder? I know that the newer machines could correct up to -4, but I'm still doubt about that. But even if you have a higher cylinder errors, what will you do with a SMILE? I think you can do a lot with the LASIK and Femto-lasik, even with the PRK and the golden procedure, which I consider it as the golden procedure, which is customized trans-epithelial PRK. Because the customized ablation with the PRK is more profiling, is more giving a very good profile after the PRK than the LASIK, because the flap preposition will reposit, will regain most of the irregularity of the corneal surface. So about ectasia too, the SMILE is not away from the risk of the remaining risk of post-operative ectasia. You have to keep the same indices to decrease the risk of post-operative ectasia, the same exclusion criteria. It is not a solution for high errors and suspected cases. A lot of cases have been reported with post-operative ectasia, and I am from Egypt. And I have my colleague, Dr. Mohammed Tariq Anagar, who was the first one reporting post-LASIK, post-SMILE ectasia in a patient with bilateral ectasia after femtosecond laser assisted with a small incision lenticular extraction, and which is very quickly and very fastly published in the Journal of Refractive Surgery without any waiting list. This case was with subclinical or permafrost keratoconus, and then he went as they thought at that time that the SMILE will decrease the risk of post-LASIK ectasia in the cases with subclinical keratoconus, but actually it was not. So they shocked with this case of bilateral ectasia after doing the SMILE. Followed by reports by the random man about the ectasia after SMILE. Tariq Anagar started the reporting of that cases, so a lot of surgeons after reporting and started to publish about reported cases of post-SMILE ectasia. Finally, ectasia, which is the most recent, 2017, and we have a lot of other reports about the post-LASIK ectasia, and finally they conclude that a majority of cases of reported ectasia cases occurred in patients with subclinical keratoconus. Have a minute, yes. And finally, for now, we propose adopting the same exclusion criteria used for LASIK in the SMILE procedure until more specific metrics have been validated. So I have to conclude that the Femto-lasik is more preferable to me than SMILE. It's more planned. I think it's more planned. I can do just one cut and I can complete safely. I can manage everything about my flap. If I got any flap complications, I can postpone my case and can replan again. But with a SMILE, I cannot. It's more planned and reproducible procedure, more suitable for customized plans. If suspicious cases, both of them will be excluded to do PRK or cancer refractive cancel the keratorefractive procedures and going to the fake ILs. And thank you very much.
Thank you, Dr. Hosam. I also thank all the speakers and the delegates for your kind attention. So we are running short of time. We'll be wrapping up the session. Thank you.